Department of Geriatric Medicine grand rounds. Before I introduce our speaker, we have some housekeeping items. This CME activity is sponsored by the Hawaii Consortium for CME, which is a joint venture between the HMA and the Johnny Burns School of Medicine, University of Hawaii. Evaluation forms are on our website or by following the link in the chat box. Your comments are very important to our planning committee, and we use these for future programs, so please enter your evaluations. At this time, please enter the names of all attendees for CME attending purposes into the chat box. As you know, all sponsors of CME are required to execute a conflict of interest policy. Speakers can disclose whether they have real or apparent conflicts of interest. Dr. Fischberg has disclosed that he has no relationship with commercial supporters. That could be a conflict of interest. So it's my great pleasure to introduce our speaker, Dr. Daniel Fischberg. He is the medical director for the Pain and Palliative Care Department at the Queens Medical Center in Honolulu. He's also a professor and chief of the Division of Palliative Medicine in the Department of Geriatric Medicine at the University of Hawaii. He holds board certifications in internal medicine, pain medicine, addiction medicine, and hospice and palliative medicine. He's also a fellow of the American Academy of Hospice and Palliative Medicine, where he serves as the chair of the Academy's Education and Learning Strategic Coordinating Committee. He's recognized as a national expert in the areas of pain and palliative care education for healthcare professionals, improving access to palliative care for patients at all stages of illness, and advancing evidence-based practice in palliative medicine. So without any more, I want to go ahead and introduce Dr. Fischberg. Please go ahead and start, Dr. Fischberg, and thank you so much for joining us today.
Oh, thank you so much, Dr. Masaki, and thank you very much for everyone for being here today. I will confess the request for the topic came from Dr. Masaki. She thought it'd be a good topic for us to get all on the same page here in July. And I always do have a little bit of nervousness when I'm talking about anything near end of life, and that people might misconstrue that palliative care focuses on care at the end of life. That is an important but small part of palliative care. I would, besides the pain management talk we're going to be doing, please keep in mind that we really do think of palliative care as being based on needs, not prognosis. So some of the patients referred for palliative care might be being treated with curative intent. But nonetheless, the topic today is trying to get it right in the last hours and days and weeks of life. And so we're going to be talking about pain management near the end of life. As objectives, we're going to talk about some of the standard approaches to pain management near end of life. We're going to talk about 3 reasons for opioid refractory pain. Opioids are pretty good for pain management, but you will encounter situations where just more and more does not get you the result you're looking for. And then to sort of a little bit of a bonus, I'm going to throw in a little bit of material on using opioids to manage dyspnea, as well as pain at end of life. As you've heard, I have no relevant financial conflicts to disclose. I do have another disclosure though. I am not a digital native. So your patience is going to be appreciated, because this is actually, well, it's not the first Zoom talk I've given in the pandemic. It's the first one I specifically developed in it. And I'm sure you all have just as much Zoom fatigue as I have. And so this talk will not be filled with New Yorker cartoons the way I'm accustomed to operating, because I couldn't hear people either laugh or groan when I shared the cartoon. So this is going to be a very interactive and case-based presentation. So limber up your fingers and have your keyboards handy, because I am going to be asking you to participate as we go through some cases and use that to prompt our discussion, okay? So here's our first case, Mr. Kurosawa. He is an 83-year-old man with end-stage metastatic prostate cancer, and he's at home receiving hospice care. His family brings him to the emergency department due to uncontrolled abdominal pain, despite morphine liquid 20 milligrams by mouth every 4 hours. And he's admitted to your service at the hospital for comfort care. So, how would you approach Mr. Kurosawa's pain? And now I'm going to load the poll up. So, would you like to increase his morphine to 25 milligrams every 4 hours? Would you like to start a 50 microgram per hour fentanyl transdermal patch? Would you like to start a morphine IV infusion at 2 milligrams per hour? Would you like to obtain and perform a focused history and physical? Would you like to order a CT scan of the abdomen with contrast? Got about a third of people have voted with their fingers. I'll give you a couple more seconds to vote. I know some people can hum that Jeopardy theme, but your ears would crack if I tried. Okay, we're at 60%. We're going to go with that. And I'm going to share the results. Hopefully you're now seeing the results. This is the be patient with the non-digital native part. So you can see that we had some people thinking about increasing his morphine by about 25%. And we'll talk about what we think about that. Some people had two answers for start a fentanyl patch. Nobody wanted to start the morphine infusion, but the lion's share of you came up with what I was looking for, which is to obtain and perform a focused history and physical exam. Because if you did, you might find out that Mr. Kurosawa's last bowel movement was sometime during the Eisenhower administration, and when your physical exam includes a rectal exam, you're going to find out that he's horribly impacted, and you disimpact him and his pain requirements go down to 0, and he actually can be discharged home. Okay, let's move on. So we're going to talk a little bit about pain assessment. Just like in real estate, location, location, location. Then I've been a fan of the OPQRST approach. So when did the pain start? Well, and maybe it started, when he had his last bowel movement a couple of weeks ago. Provocative and palliative. What makes the pain better? What makes it worse? What's been tried? What's been tried ineffectively so you don't have to repeat anybody else's mistakes? Quality. I guarantee you, just don't use the word quality when you're trying to assess quality of the pain, the characteristic of the pain. If you ask somebody what's the quality of their pain, half the time they're going to say they have no quality. That's why they're coming to see you. Here's a pearl. I was taught once the best way to get what we're looking for here with quality. We're trying to figure out, look, is this a nociceptive somatic pain? Is this visceral pain? Might it have a neuropathic component to it? And remember, please, pain can be purely neuropathic or mixed. And so I was taught, could you describe this pain so I could understand it as if it were happening to me? And then a lot of times, people that were struggling to come up with any kind of descriptions will often be able to give you something. And of course, when you give up, you just start giving them the laundry list. Is it sharp? Is it dull? And so on. But best to ask those sort of open-ended questions first. What about R? Is it radiation related? Does the pain go anywhere? Does that pain just hang out in your butt, or does it run anywhere, like down the leg? Or they're related symptoms. So it feels like an elephant sitting on your chest. Do you have any other symptoms when that elephant is sitting on the chest, like nausea or palpitations or lightheadedness? Severity. Now everybody, of course, is familiar with our 0 to 10 pain scale. Some people use 1 to 10, but I do prefer 0 to 10 because I'd like to imagine a world where there's 0 pain. But please also make sure you try to ask some verbal qualifiers. So you will be surprised when you ask someone 0 to 10, where 0 is no pain and 10 is the worst pain you could possibly imagine, how much are you having now? When they say it's a 9, and then you ask them, would you say, is that mild, moderate, or severe? You'll be surprised the number of people would say, oh, it's a 9, but it's moderate. So don't assume a number and a verbal label will coincide. And then the point I really like to emphasize under severity is really, it can be whatever number they want or whatever word they want, but what does the pain keep them from doing? What is its impact on their physical, emotional, and social functioning? That's that's a needle that's much easier to budge, help them get a little more functional. And the number might not change, right? So the patient gets admitted, it's a 7 out of 10 and they're bedbound. You do your assessment, you do a lot of pain management, and they're up and walking about, and it's still a 7 out of 10 because many people will push themselves until they reach a number where they can't function anymore. So the patient is still a 7 out of 10, if you were just looking at the number, you'd say that was a complete failure. But if they're now up and moving around, you've restored their function, it's obviously fairly successful. So please remember, when you're looking at severity, emphasize the functional impact. And then the temporal pattern. How long has this been going on? Not only when it start, but is it the same day or night? Nighttime pain that's a lot worse at night, when the patient is actually less active and less mobile. Sometimes will make you scratch your head and wonder. Sometimes neuropathic pains talk a little louder at night when there are distractions. But sometimes when people are alone with scary thoughts, their pain can get a lot worse too. So sometimes that is a little bit of a clue to what's going on, the temporal pattern. Okay, so near end of life, you certainly might need additional informants. The patient may be so delirious from all the morphine they were getting that they can't give you a good history, or for whatever reason they may not be able to provide you a good history, especially if their level of consciousness is diminished. And an appropriate exam will supplement your history, and then figuring out whether Mr. Kurosawa was really going to need a CAT scan or a plain film. That's sort of going to be guided by your history, your physical, and then how much time you think there might be, what the prognosis is, and the treatment goals. But please remember, there are you can get imaging studies done, and even for a homebound patient, you can get plain films done if you think it's going to improve the patient's quality of life or length of life. You can do that. Okay, let's move on to case number 2. So Ms. Hitchcock is an 87-year-old woman with advanced dementia, and she's become more agitated at her care home over the last 6 months. Understanding that behavior is communication, you wonder if she might have unmanaged pain. So you learned from the first one, you did a comprehensive assessment, but after the comprehensive assessment, which one of these might be appropriate for an empiric trial? I'm going to load our second poll now. Okay, so you could do acetaminophen, 650 milligrams by mouth every 4 hours as needed. You could do acetaminophen 600 by mouth 3 times a day. You can do naproxen 550 by mouth twice a day. You could do gabapentin 100 milligrams 3 times a day. Gabapentin 300 milligrams 3 times a day. Okay, while everyone's voting, I want to thank Dr. Galbraith for at least smiling or laughing in the chat box on one of my jokes privately. Thank you, Jeff. You're a good friend. Okay, we've got just over 50% of people voted. Okay, we're going to end it. Okay, so definitely people like the acetaminophen, but looks like to about greater than a 2-to-1 margin, some people wanted to schedule it, and that was in fact what I was looking for. Acetaminophen is a very reasonable starting point for an empiric trial for somebody like this. But again, I just remember this patient does have advanced dementia, so the PRN dosing of it is going to be problematic, right? You don't know, you don't want to wait till the patient is agitated. The patient is not really able to give you a proper complaint about the pain. So generally, if we're doing a trial like this, we would rather try to prevent the pain than chase after it. So that's why I was looking for that. Naproxen, it's just, as an NSAID, it probably wouldn't be our first choice in a patient this old, given the potential for toxicities. Thank you, the 3 people who voted for gabapentin. It's becoming a bit of a popular choice these days, but I really hadn't given you anything that made us think this was neuropathic pain, and So generally what we're seeing with gabapentin is it's getting prescribed an awful lot now, and the indication generally is not a neuropathic pain condition as much as the prescriber does not want to give an opioid. That seems to be the main indication that gabapentin is being used. So not a lot of great data on gabapentin for generalized pain, and even not great data on it for lots of neuropathic pain conditions for which you see it being used off-label. But there you go. That's why I put it up there. Be thoughtful when you are throwing gabapentin. Are you treating yourself and your discomfort with giving an opioid, or are you actually, do you have a pretty good theory that this is a neuropathic pain syndrome that might respond to the gabapentin? Okay. So our World Health Organization Analgesic Ladder, it's old, but still can be helpful. Just remember that, you know, this sometimes how we start thinking about when we use the opioids, when we use the non-opioids. So typically for milder pain, we're not using opioids. We might be thinking the non-opioid analgesics plus or minus an adjuvant. The weak opioids, which typically, it's a misnomer, they're not really weak opioids, they're just opioids that are in combination products like an oxycodone with acetaminophen or a hydrocodone with acetaminophen. And it's that combination that quote unquote weakens them because they're just in fixed doses, unlike the strong opioids, which are just not accompanied with any non-opioid, and so not dose limited. Please remember, when you are using those combination products, that means you're the one who's responsible for keeping track of how much acetaminophen they're getting with every combination that they take, and you do want to be mindful that you're not exceeding a recommended daily dose of acetaminophen, which many of us now are thinking 3 grams or less in the general population, and 2 grams or less, and for seniors or those with some hepatic dysfunction. So let's move on to case number 3. Mr. Truffaut is 67 years old with advanced pancreatic cancer. He presents to the emergency department with severe epigastric pain, despite, and this is his home regimen, morphine sustained release, 60 milligrams by mouth twice a day, plus morphine immediate release, 30 milligram liquid that he's taking every 4 hours around the clock. And look how kind I've been. I've actually done the math for you. That works out to a morphine equivalent daily dose of 300 milligrams, okay? So 60 twice a day is 120, and then 30 every 4 hours, which is 6 times a day, is 180. So 120 plus 180, that's how we calculate the 300 milligrams morphine equivalent daily dose. So after a comprehensive assessment, which one of the following would be appropriate first step? I'll load our next poll. So do you want to start a 50 microgram per hour fentanyl patch? Do you want to start a 100 microgram fentanyl patch? Do you want to increase the morphine SR from the 60 twice a day to 120, a doubling? Would you like to give a morphine 4 milligram IV push? Or would you like to give a morphine 10 milligram IV push? And I'm going to give you some time to think about that. You don't have to be shy. I've only seen about a third of people voting so far, and there is more spread on this one, so don't be embarrassed. You always got to start out easy, right? And work our way up. All right. Come on, push us over the 50% mark. There you go. Okay. Okay, so let's look at our results. So actually, the majority of you wanted to start a 50 microgram patch, and that's not what I was looking for here. So this is a good opportunity for us to talk about a couple reasons why I don't think that would be the best solution in this case. So there's a nice rule of thumb. Remember, I told you this patient was on 300 milligrams morphine a day. There's a rule of thumb that if you basically take the number on the fentanyl patch and double it, that's about equal to the morphine equivalent daily dose. So a 50 microgram per hour patch would be about equal to 100 morphine equivalent daily dose, which is only less than like a third, is like a third of what he's already taking, and which is not controlling his pain enough that he has to come into the ER. So that's one reason that's wouldn't be the right answer. And I wouldn't like the 100 microgram patch either. That's still only 2/3 of what he was taking at home. How long does it take for a fentanyl patch to reach effect? This is a patient, remember, who's in the emergency department with severe pain. Fentanyl patch might start to reach its peak somewhere around between 12 and 24 hours. The number, I think, 17 hours is on the product insert. That's not an appropriate response time for somebody in a pain crisis. So a fentanyl patch is really not good for an acute exacerbation of chronic pain. Certainly not good for acute pain. It's only for the opioid tolerant. This is clearly an opioid tolerant patient. That's not a problem with the answer. It's just that the doses I've given you for the fentanyl are a little too low, and also it's just not an appropriate response. It takes too long. Doubling the morphine SR, we'll talk later, that's not an inappropriate amount to double, but you're doubling it to 120 twice a day, which would be 240, which is still less than the 300, which is not controlling his pain. That's one problem with that answer. And the other problem is, again, it's just, you're unlikely to, get the kind of fast response. So yes, I was looking for the IV doses. And actually, more of you went with the 4 milligram dose, and I was actually looking for the 10 milligram dose. And that might seem robust, but what we often will say, I'm just going to go through the numbers here with you. Typically, so we want to dose find with a short-acting opioid. Okay, that's why we don't know what dose this patient needs, so we're not going to use a fentanyl patch or sustained release morphine to figure it out. We're going to use a short-acting opioid. If you're at home, you could do it with orals, but he's in the emergency department and he's having severe pain, so we're going to use an IV. What I've put up here is that about 10% of the morphine equivalent daily doses would usually be considered a safe and possibly effective dose. We don't know what he requires, but we should not hurt him by giving him this. So I did the math for you. I said that he was on 300 milligrams of morphine equivalent daily dose. We need to convert that to IV. So that would be about 100 milligrams of IV morphine per day. 10% of that, that's how I got the 10 milligrams. You're not going to hurt him with the 4 milligrams, but it would be a little surprising if it did much for him because it's such a small fraction of what is already not controlling his pain. I've already put down here, remember that the fentanyl transderm doesn't start to level off until the 12 to 24 hour mark, so it really isn't appropriate for a rapid response. And remember, steady state is not achieved until you hit 4 to 5 half-lives of a drug. So this brings me to one of my favorite pet peeves, drips. If I gave you a case with somebody who's on a drip, and I see this pretty often, that people will adjust the infusion rate rather than give a bolus dose. And that's just, if they're on a morphine infusion, that's a half-life of 2 hours or so. So you're talking maybe 8 to 10 hours before you actually see the full effect of what you just did. That's an inappropriate amount of time for the patient in pain to have to wait. And so what invariably happens is they increase the infusion, and then you end up overshooting. So give the bolus, you'll see the effect within minutes, and then you can assess if it was effective, how much, based on that, what do I want the hourly amount to be increased by. So bottom line here, when titrating with opioids, use your short actings, whether it's an IV bolus or an oral short acting, before you, and get pain under control before you start using a long acting like a patch or a sustained release formulation. Okay, so fortunately, Mr. Truffaut's pain gets under control. You send him for a celiac plexus block, which works fantastically. It reduces his pain and markedly reduces his opioid requirement, so he doesn't have to be taking such high dose opioids. And 3 months later, the pain starts to come back. It starts to worsen, and you send him back for another block. The nerves have regrown. So while we're waiting for the appointment for the repeat neurolysis, what would be a recommended amount to increase his baseline opioids for moderate to severe pain? Here's our next poll. Go for it. Would you increase 10 to 20%, 20 to 50%, 50 to 100%, or 100 to 200%? Going to give you a couple more minutes, seconds, I should say. Okay. Okay, so a little bit of spread here. 8 people said 10 to 20%, 20 people said 25 to 50%, 13 said 50 to 100%, and 1 said to 100 to 200%. Unfortunately, this is a little bit of a read my mind kind of game, but in general, for moderate to severe pain, we'd be talking about the 50 to 100%. So let's talk a little bit about that. So generally, this is just sort of expert consensus opinion. This is what we talk about. So when an increase is indicated in opioid therapy on somebody who's tolerating the dose but just getting inadequate relief, we typically think about 25 to 50% increase for mild to moderate pain as something that has a potential to be tolerated and effective, and 50 to 100% for more moderate to severe pain. So for this gentleman, we were looking for a 50 to 100%. Because I gave you that he was having moderate to severe pain. And that's just something you kind of got to remember. We'll come back to it in the summary. Okay. While we're in the numbers section of the talk, people often ask, how do you calculate what percent of the daily opioid dose is used when you're thinking about rescue dosing? Some people don't do it based on a daily opioid dose, but that's how you're supposed to do it. You're supposed to basically say, well, if this person's on 300 milligrams, I take percent of this, 300 milligrams a day, equivalent percent of this. So this is our next poll. So what percent do we use of the daily opioid dose for PRN or rescue dosing? And I have to say, it's very nice. You guys are giving me a nice spread of questions. I would feel so depressed if you got them all right. So I won't sing to you, but a horse walks into a bar. Bartender says to the horse, "Why the long face?" Okay, thank you for your polling. Let's see what everybody said. Okay, pretty evenly split. So again, this is just expert consensus opinion. It is the 5 to 15% that about a third of you got is the answer. So generally, people talk about 5 to 15% of the morphine equivalent daily dose as a potentially safe and effective option for PRN dosing. It's too hard for me to remember two numbers, so I just go with 10%. And 10% is a very easy number in terms of doing the math. And then you can just remember you could go up or down by 50%, right? Okay, let's do our next case. So Miss Bergman is 84. She has end-stage lung cancer. She's currently on best supportive care. She's admitted to the hospital with worsening dyspnea. The workup, including a CT angiogram of the chest, reveals no reversible causes, no pulmonary embolism, no pneumonia, only worsening of the underlying lung cancer. After a long discussion with the team, Ms. Bergman and her family agreed to a comfort-oriented approach to her care, including a do not attempt resuscitation status and a referral for hospice care. Their priority is to get Ms. Bergman back home for her final days. She remains, however, severely dyspneic despite a 100% non-rebreather mask. So, which of the following is the best next step to relieve Ms. Bergman's dyspnea? High flow oxygen, non-rebreather mask, morphine 5 milligrams by mouth, morphine 5 milligrams intravenous, or morphine 5 milligrams via nebulizer. So I'm looking at the chat box and nobody even groaned at that horse joke. I can't believe it. Gonna give you a little more time. Coming up on 1 minute. I don't know, Lauren. What does a fox say? Okay, I'm getting distracted by the chat box. Okay, so again, nice spread. So some people said high flow oxygen. You know what? I was sneaky here. I didn't even tell you she was hypoxemic. And what do we know about oxygen for dyspnea? It works pretty darn well if you're hypoxemic, and not at all, really, not really any better than air if you're not hypoxemic. But even if, grant you, I set it up that, you know, she's in respiratory failure. So let's say she was hypoxemic. High flow oxygen, it's going to be hard to meet her goal of getting home, right? Educate me if you can, but I have not been able to get high flow oxygen in the community here. It's pretty much a tether, a 1-point restraint that's going to keep somebody in the medical center. We can get them out of the ICU, but not out of the medical center on a high flow cannula. It can be used for comfort care. We do have a policy for comfort care with high flow oxygen. In terms of trying to get her home, that wasn't what I was looking for. She's already on the non-rebreather mask. I think that was an oversight for me to even put that in there. But you guys didn't fall for it. The morphine 5 milligrams PO, yes, that would be what many people would recommend as a trial to see if it might help with her dyspnea. The morphine 5 milligrams IV, just a little on the generous side when we're talking about managing dyspnea. Usually we're using slightly lower doses to manage dyspnea than pain. Again, the goal was to get her home, and so that might just be a little bit of a judicious dose. And one person generously went with the morphine via nebulizer, and morphine by nebulizer works. It just doesn't work any better than saline by nebulizer. So that wasn't what I was looking for. Okay. So plenty of guidelines support the use of opioids for severe dyspnea. The American Thoracic Society, American College of Chest Physicians, the American College of Physicians, the Canadian Thoracic Society, and then our NCCN, National Cancer Comprehensive Network guidelines all support opioid use. Something that you know, I have to admit, I've always felt that this was a class effect. I had no evidence for it, except for the fact that there's some data on hydrocodone for dyspnea. But some of the more thoughtful people, or at least the leaders in this field, are questioning whether opioids for dyspnea, whether that's really a class effect or whether there's certain drugs like morphine that might be best. I'll admit something that always sort of has given me hives is a patient who formerly had an adverse reaction to morphine, did well with fentanyl for months or years, now is adjudged to be dying, and so everyone feels they have to put the patient back on morphine because that's the death drug. And that would always, make me very skeptical. But I think it's an open question, and I'm a little more open to this, whether this is really a class effect or morphine might be best. So I'm just raising that to you. The quality of the evidence out there to answer this question, it isn't there yet. So I think maybe in years to come we'll figure out. So I kind of, like I said, my practice has been I found all opioids can work for this, but we know that that's anecdote, not data. Again, I already shared this with you that nebulized opioids have been shown effective, but when compared to saline, they're not superior. And this is the key point really in this whole section of the talk, is that whenever it's been looked at, when we're talking about judicious use of opioids, and that would be more like than 5 milligrams by mouth, not the 5 milligrams IV, which would be essentially triple that dose, right? Because morphine has about a 3-to-1 bioavailability. So there's really no evidence when you look at it that patients given these kinds of low doses of opioids have a hastened death. And so that's why all these guidelines support their use as a strategy. Okay, so I got Mr. Lee, and he's at home with hospice, and he's got end-stage renal disease and heart failure. And you're called by his family that he has been moaning and restless despite escalating morphine from the hospice's comfort pack. So what's the most likely cause of Mr. Lee's condition? This is my last poll, I think. Okay. And those of you that figured out that these are all famous movie directors, you can decide whether this is Ang Lee or Spike Lee or thank you, Lauren. Just a few more seconds. Okay. Oh, come on. I know we're at a minute, but only 45% voted. Don't be shy. I'll tell you there's even spread. So if you're wrong, you're going to have lots of company. All right, we're at 50%. Good. Okay. Well, 3 said opioid refractory. I'm sorry, opioid refractory neuropathic pain. Could be, but I didn't really give you any evidence for that. Opioid refractory existential depression. Yeah, it could be, I guess, but again, I didn't give you much for that. Opioid-induced hyperalgesia was a slight preferred answer. And there could be an element of that, but I was really setting this up as more delirium because we're using morphine in a patient who has end-stage renal disease. And it's getting worse and worse. And we actually didn't comment on anything about him having a pre-existing pain condition. But none of these are wrong answers. So let's talk a little bit about Mr. Lee's situation. Thank you. Hopefully none of you said addiction. That's good, because I really gave you nothing on that. Okay, so we have this syndrome of opioid partially, poorly, or refractory syndromes, and if we didn't, then many of us would be out of a job because it'd just be a matter of giving more opioids, right? That fixes everything. So definitely neuropathic pain can be part of a poorly responsive pain syndrome. be a misstatement to say that neuropathic pain is opioid unresponsive, right? It's just neuropathic pain is inherently difficult to manage, and so opioids work for neuropathic pain. They just don't work as well as they do for other pain syndromes. So oftentimes we'll need to combine an opioid with an agent specifically for neuropathic pain. Opioid-induced hyperalgesia, yeah, that's a thing. I think some people see it everywhere they look. Some people never see it. But yes, this is a syndrome of opioid-induced neurotoxicity. You typically see signs of CNS excitation. So you see delirium and myoclonus, and then the key is the more opioid they get, clearly the worse the pain gets. And that's sort of the most dramatic when you have a patient who's on a PCA, who's not so delirious that they can't talk to you. Will say, it's the darndest thing, doc. Every time I push this button, the pain actually gets worse. And when that happens to me, that's a pretty good sign that this is opioid-induced hyperalgesia. Delirium, and I think that's probably the most common explanation for this kind of syndrome. You've got a patient who has end-stage renal disease. They are going to be susceptible to developing toxicity, especially from morphine, which would not be the preferred opioid for somebody with end-stage renal disease. And then you'll encounter this a lot of times, right? We find obviously pain is modified by anxiety and mood, and it's not to say that pain doesn't exist, but it's greatly modified by the anxiety and the mood, and you might make a lot more progress with the pain management by identifying and treating the anxiety or the mood issue. And similarly, you can see the same thing for spiritual or existential distress. If someone's terrified that they're going to the hot place, or just dealing with the concept of their finality, there's no amount of morphine that's going to fix that problem. Whereas a good listener, a good spiritual counselor, a good chaplain can often make much more progress than a bathtub full of morphine. So, as this is a quote that's typically attributed to Albert Einstein, the definition of insanity is doing the same thing over and over again and expecting a different result. And so I think that's when you run into these difficult syndromes, you just have to say, whoa, let's stop. Doubling the dose every couple of days, we're not getting anywhere. What are we missing? And it could be any one of these things that I've talked about. So just to reevaluate why, 90% of the time when I go up on the morphine, things get better and everyone's happier. What's going on in this situation where I go up and nothing's happening? And of course, there's a broader differential here. Of course, if the patient, for example, isn't receiving any of the morphine because it's going out the back door from some family member, that's also in the differential. Okay, so I'm going to wrap up now. We have a little bit of time for questions, but the points I wanted to make this morning are that really you got to start with a proper assessment, and that's going to guide your management at all times, including near the end of life. Think about pain as a cause for unexplained agitation in a patient with advanced dementia. And then again, think about maybe scheduling something like acetaminophen just to see if the behaviors improve. When you start and titrate, when appropriate with an opioid, please remember to use the short-acting opioids, not the long-acting opioids. And then there are these numbers that I threw at you midway through the talk. Typically, for mild to moderate pain, if it's appropriate to go up on the opioid, we think about 25 to 50% is typically a safe and effective amount to increase. For moderate to severe, we think about a 50 to 100% increase. And then remember that 5 to 15%, or if you're lazy like me, 10% of the morphine equivalent daily dose for PRN rescue dose calculation. Remember, please, that judiciously used opioids, and we're talking about maybe 5 milligrams of oral morphine equivalent, which would be less than 2 milligrams of IV, can safely relieve dyspnea and can really make a big difference. in someone dying comfortably or even being able to get home for end of life. And if pain is poorly opioid responsive, reassess for many things. And I've got your list here of some of the more common things. Perhaps there's a neuropathic component to the pain that we haven't assessed and that's incompletely opioid responsive, delirium, and the fact the opioid is maybe driving it. There's existential distress, undertreated anxiety or mood disorder, or the opioid's actually making the whole situation worse by opioid-induced neurotoxicity. So that's it. Thank you very much for playing along and for your participation in the polling. You were really good sports. I appreciate that. And let's see if there are any questions that come up in the chat room. Thank you.
Dr. Fischberg, thank you so much for an excellent presentation, extremely informative. If any of you have questions, could you please type them into the chat box at this time? Please type your questions into the chat box. Dr. Fischberg, it seems like you've done such a wonderful job that nobody has any questions at all. Give them a little bit more time just to be sure. Okay, here we go. So here's one question, Dr. Fischberg. When is the best time and what is the best patient to use a fentanyl patch?
Okay, well, that's a good question. Thank you. You know, it's one option. When do I think of it? Well, when you think you have a good sense of what the patient's opioid requirement is mostly what I was emphasizing here. When you're not going to be going up and down a lot, because I'd say it's the worst choice when you're trying to titrate, right? Because it takes like a day to hit its peak, and it's actually not at steady state for a few patch changes. So generally, so I would start with that. Somebody who is on a steady dose. Then you know, that we do have some evidence that very cachectic patients maybe are not going to absorb. You do need some body fat to develop that depot. So somebody who has is very, very thin, cachectic, may not be a good candidate. You know, but in general, for quality of life, if they meet the criteria, that is, they're on stable doses and they have some body fat and they're appropriate for opioids. A lot of people like the convenience of the once every 3 days rather than the twice a day pill. There's some soft evidence, pardon the pun, that bowel movements might be a little easier when we're giving the opioid transdermally rather than directly into the gut. So those are the kind of folks I think about for, and I guess I kind of, because fentanyl is a preferred agent for people with renal dysfunction, older patients might be somebody I would think about it more often, again, if they're appropriate for an opioid and if they're on a stable dose.
Thank you very much, Dr. Fischberg. This is another very interesting question. How do you handle families who refuse opioids for the dying patient?
Dr. Samoji, I've never heard of this situation. I can't, just kidding. So, I think it's, thank you for the question, MSA. I think it's like everything else, we have to come at them, come alongside them, not at them, non-judgmentally and with question, just genuine curiosity. What are they worried about? We know we want the same thing 99.9% of the time, assuming the family's not psychopathic and or doesn't have the patient's best interest at heart. In general, we both want the best outcome for the patient, so we just got to start with what they're worried about, and then maybe negotiate. They're really terrified about giving that 5 milligrams of oral morphine. How would they feel about 1? Just starting with the lowest dose possible. But I think we have to just come with a genuine curiosity about what it is they're worried about, respect that, and then, as they're willing to hear it, provide some reassurance. And, of course, I'm sure we've both encountered people that aren't really interested in hearing anything else. And, you can only do so much. But, those are tricky situations. But I think a lot of people, it's fear-driven, and there's maybe just, you know, all they know is that the person next door was on hospice, and the day they took the morphine was the day they died. And of course, you know, we know about that association, and it's not causative. It's just that the patient, you know, developed some terminal symptoms on the day they died, and were appropriately given morphine, but there's that association. So, you know, I think in my experience, the vast majority of people, when you come alongside and figure out where they're coming from, and they you know, build some trust, you can get there. And then there's some who are not reachable. What are you going to do?
Thank you, Dr. Fischberg. The next question is, can we give scheduled Tylenol in a patient with pain which could be related to infectious etiology? For example, an intra-abdominal infection like spontaneous bacterial peritonitis.
Yeah, that's a good question. I'm trying to guess where you're coming from there. Is the concern that you might be masking the pain, and therefore the patient's going to have a catastrophe? I mean, the short answer is yes, you can do it. And you, more commonly, that question is, could you give an opioid? Like there was the big conflict was patients presenting with abdominal pain, unidentified abdominal pain, possibly an appendicitis. You know, the old teaching, and it was in surgical textbooks for decades, was you can't give them an opioid because you're going to mask the pain and you'll have a bad surgical outcome. And that's been proven wrong. And that's just, it's no longer in the surgery textbooks. So if that's where this question is coming from, whether you're worried about masking fever or masking pain, I know of no evidence that there are worse outcomes because of that.
Thanks, Dr. Fischberg. Are there any other questions? Please type into the chat box in the next minute. Dr. Fischberg, this has been a really nice comprehensive review, and especially with our new fellows who just started July 1st, I think it's great that we have this topic this month so that they can move forward into their patient care armed with some of these facts.
Thanks for having me, and thanks for suggesting the topic, Kamal. I appreciate it very much.
Okay, thank you everyone, and see you next time. Thank you again, Dr. Fischberg, for a wonderful talk.
My pleasure. Thank you. Aloha.
Okay, take care. Bye-bye, everyone.